Breast cancer is the #1 cancer in American women, with the exception of skin cancer. What is concerning is that the number of cases is increasing. Luckily, throughout Catholic Health Services, we have physician experts and specialists dedicated to diagnosing and eradicating breast cancer. St. Joseph Hospital in Bethpage provides outstanding state-of-the-art services to women, including the early diagnosis and treatment of the cancer and other non-cancerous breast problems. On today's episode of CHS Presents Lifestyles at the Heart of Health, we will explore this topic and discuss why it is so important to be screened for early detection of breast cancer. Hello, everyone, and thank you so much for joining us. I'm Jane Hansen. Today's conversation, St. Joseph Hospital's breast program. To speak more about women's services, breast disease, breast cancer is Dr. David Kaufman, Chief of Breast Surgery at St. Joseph. Welcome. It's so good to have you here. You've been practicing and working in this field for a very long time, and now here we are talking about increases in the number of women getting breast cancer. What's that all about?
Well, we're really not sure why the incidence is increasing. We think it's multifactorial. The population is growing, population is aging. We have better technology, so we're finding more of them. But I think that the disease is changing a little bit. I think it's becoming more of a older woman's disease, and we're seeing now more and more young women getting the disease.
Why do you think that is?
We're not really sure. Again, there are multiple factors, including toxins in the environment, things that we're no longer getting in our food sources and supply, processed foods, alcohol consumption, smoking.
Smoking? I mean, I know we keep talking about smoking, but my perception is smoking is way down.
Smoking is down, but in smokers, the incidence of breast cancer is increasing, and in breast cancer, it's increasing.
In all the stories that I've done about breast cancer in my many years as a journalist, women who get it younger have a much more aggressive kind of it. Is that still true?
Yes, it is. They do.
So that means that we have to be far more aggressive about the way in which you treat it.
Correct. It's really important for young women to realize that it can be a younger woman's disease, and they do need to go for screening. And they need to have their breast examined by their OBGYN or their internal medicine physician. They need to do breast self-examination. And when appropriate for age, they need to begin screening with mammography.
So what age should they be? I know the American Cancer Society says 45. Is that too old?
We in the industry believe that it should not be 45. Most women who get breast cancer have no family history. The incidence in families with breast cancer is high. However, if you look at the statistics across the board, most women who get breast cancer have no family history.
Wow, I'm shocked by that.
So it's important for these people and these women to realize that even if there is no family history, we don't agree with the American Cancer Society recommendations that 45. We think women should start at 40 and even younger if there is a reason for that, a strong family history or maybe even a personal history. So for instance, if your mother had breast cancer or your sister had breast cancer at a young age, you should be screened starting at 35 or even 30, or sometimes even younger, depending on your specific situation. So it's important for these women to have a conversation with their doctor about when it's appropriate to start screening.
And another thing, if you have your first child over the age of 30, there's also a greater risk. And everybody knows a lot of women these days have put off having children until they're well over 30.
Yes, we are aware that that is a risk factor. And childbirth actually is somewhat protective for two reasons. One is because childbirth and pregnancy turns off the estrogen pump. Estrogen is the female hormone. Mm-hmm. We know that that can be a cause of breast cancer, increase the risk. The second is that a lot of women who have children breastfeed. And we think there might be some protective advantage of breastfeeding children in terms of lowering the risk of breast cancer.
You know, one of the things that my mother had Alzheimer's, and one of the things that I was told was that going through menopause, you should have estrogen, you should take hormones because it will help prevent Alzheimer's. I mean, that's still not known for sure, but the suggestion from what I'm hearing is you don't want to do that because you might get breast cancer.
So replacement hormones, that is a very controversial, hot topic. There are a lot of experts who believe that taking replacement hormones to get a woman through menopause to stop things like memory loss and all kinds of issues may increase the risk of breast cancer, but we're really not sure. The answer is not in. It's still quite controversial.
So let's get back now to St. Joseph's and what you guys do there. Tell me about your program, what you do for really early intervention, and how you help a woman through that process.
So at St. Joseph, we have a wonderful breast disease and breast cancer program. We're all about early detection and prevention. So we get women into the program, we screen them early, we watch them closely, especially higher risk women, making sure they're having mammography and ultrasound and in some cases breast MRI, breast examination. If we identify the problem, we intervene early and we remove it early, and many of those cases can prevent breast cancer by removing a high risk finding. Not yet breast cancer, but may go on to become breast cancer, or may show us an increased risk for a woman who has breast cancer. So we screen them more thoroughly.
So when you say, is that like a little lesion, or what is it that you see that like precancerous?
Sometimes a woman comes in, she says, I feel a lump in my breast. We'll examine them. We feel the lump. We'll do a needle biopsy. We'll identify something that may be a precancer, like something called atypical hyperplasia, for instance. Those lesions are removed. They're not yet cancer, but they might become cancer. So by removing it, that's preventative.
So I guess the thing then you mentioned that you do mammograms and then sonograms. I mean, should everybody have a sonogram?
It's not for everybody. Certainly women who have dense breasts should have an ultrasound as well. An ultrasound is the same as a sonogram. The reason for that is because mammography sometimes can't see through very dense or thick-breasted women. The tissue's so thick that radiation doesn't penetrate. But dense breast does not inhibit ultrasound. So ultrasound can see through dense tissue. It may help us see things that the mammogram can't see. Although I will tell you that the modern mammography, what we call 3D tomosynthesis, that has helped us a lot with breast density. And we find a lot more things that were not seen prior.
Does everybody in your practice get the 3D mammography, or is that only for, again, higher risk patients?
3D mammography is now the standard of care.
Okay, well, that's good to know. And then you also mentioned the words MRI. When does somebody get an MRI?
MRI is a great problem-solving tool. It's a complex test. It's used in women who are very high risk, used in women who have had breast cancer, used in women who have a very strong family history, those who might have the BRCA gene, who might have the genetic predisposition to breast cancer. We use this as a problem solver to find things that perhaps a mammogram, sonogram do not see. It takes a deeper look inside the breast tissue.
But, I mean, so if they haven't seen something, and you're talking about these high-risk patients, but why not give an MRI to everyone, or is that just too much?
That's a great question. A lot of people ask me that question, why can't everybody have an MRI? And there are a number of reasons. One, it's a very, very expensive test. Two, it's not a great screening tool. The reason it's not a great screening tool is because the test is so sensitive, it sees every blemish and every shadow in the breast.
Oh.
So there's something called false positive, which means if we see a shadow, a woman's going to end up with a biopsy.
May not need it.
Correct. The majority of those findings are benign and it's not necessary.
Okay, so you talked about the BRCA gene. That's all a product of going through, or you find that out through genetic testing. Who should be tested? Again, is it based solely on family history? Or is it should it be a common something that every woman does?
Yeah, so about 10% or less of the population is positive for the BRCA gene. We know that we're not going to do full population screening because 90% of the women are going to be negative. So we sort of focus on that high-risk group. Who are the high-risk women? Strong family history of breast cancer. Your mother had breast cancer, your sister had breast cancer, both your grandparents had breast cancer, things like that. In addition, a woman, for instance, who has breast cancer before the age of 50, or if she had ovarian cancer, breast cancer and ovarian cancer are linked together. the same gene can identify the risk for both of those diseases. So that's the population that we try to focus in on, but I will tell you the dynamic is changing. There is a push now to do general population genetic screening. And so it's very expensive. I don't know where the money is going to come from to do that, but stay tuned. Within the next couple of years, there's going to be a huge push to screen everybody.
For every kind of genetic disease?
Well, I can speak directly about breast and ovarian cancer, but more and more people are doing full panel genetic testing for everything.
So when you do discover that you have the BRCA gene, do you do like Angelina Jolie did and have your breasts and your ovaries and your uterus removed?
So if you are BRCA gene positive, you have a lifetime risk of getting breast cancer about 85%. And you have
Pretty high risk.
Very high, almost certain. And you have about a 45% chance lifetime of getting ovarian cancer.
Which has very little symptoms. So it's almost too late once you discover you've got it.
Correct. Those diseases are usually found later on because there's no screening test for ovarian cancer. So we would remove the tubes in the ovaries. That would get rid of the estrogen. It would lower the risk of breast cancer and ovarian cancer, and then remove the breast as well.
And is that something that you highly recommend to those women who do indeed test positive?
It's a conversation you have with every woman. It's not one size fits all. It's a tailored approach, case by case. For some women, it's great. For others, it's not. We do a lot of that in our practice. Bilateral, both breast removed and reconstruction. And women are thrilled by that because they get rid of that lifetime risk of breast cancer.
And I guess at the end of the day, we did start out by saying the survival rate, the number of deaths from breast cancer has greatly decreased, which is the good news in all of this. Early detection, the methods that you're talking about, everything you're doing. So when you're diagnosed with breast cancer these days, unlike like it was 20 to 25 years ago, it's not a death sentence.
Correct. It's a different disease today and there's a different treatment today, thank goodness. 20, 25 years ago, everybody got the same treatment. It was one size fits all. Everybody got the same chemotherapy, the same radiation. Today, it's tailored. We identify your cancer, we study the cancer, we learn its specific personality, if you will, and we know how to address those specific cancers. So the death rate is going down, the cure rate is going higher, and it's wonderful. And I predict that within the next 5 years or so, early cancers are going to be curable almost all the time.
That would be so wonderful. How fabulous would that make you feel? And me.
Outstanding.
All right. We're going to take a quick break. And when we come back, we are going to be speaking with a woman named Lisa Hansen, no relative, a patient at the Cancer Center at St. Joseph Hospital. We'll be right back. Welcome back to CHS Presents Lifestyles at the Heart of Health. Joining me now is Lisa Hansen, a patient at the Cancer Center at St. Joseph Hospital. So Lisa, tell us your story because you do not have breast cancer, but you've got some signs that are pretty scary.
I do. So I had my mammos and sonos that have come back luckily fine, and Dr. Kaufman had recommended an MRI, which found LCIS, which is luckily is non-cancerous.
But what is that? It's like a little lesion or
It
a
is.
little lump kind of thing?
It is. And basically it puts me at a high risk for breast cancer. So I had that removed. The cells around it were tested. Luckily that right now, that was all benign. And I had my 6-month follow-up, and another one came back in another spot. So now I'm continued to be high risk.
Are those kind of like calcifications, or is it a different?
I believe it's different because I have had calcifications in the past, and nothing had to be done about those. So this is different.
Okay, so you said you had an MRI.
Yes.
Even though the sonograms and the mammograms had been clear.
Yes.
Why then was a suggestion for the MRI?
Well, I had repeated calcifications, and after speaking with Dr. Kaufman, I have a small family history of breast cancer. I have dense breasts, and honestly, I feel like he just had a feeling, and it was just as a precaution, let's make sure we cover all bases. Let's get you an MRI. And which we did, again, after having a clear, perfect mammo and sono. I went for the MRI, and this finding appeared.
So that was so that was removed. Then you
Yes.
went back and you found another one.
Yes.
Now what?
Well, now I will have another lumpectomy to have the second one removed. But there's a possibility that this could come up every 6 months. It's not something that's going to go away, most likely. So I have a few options, but right now I think what I'm most comfortable with is a bilateral mastectomy.
Really, a double mastectomy. Now you were also tested for the BRCA gene,
Yes.
right?
Yes.
And don't have the results yet.
Not yet.
And if they come back positive, what are you going to do?
I will schedule the surgery probably the next day.
Yeah.
And most likely, yes, have my ovaries and my uterus removed as well.
That's a really big decision to make. And you're making it based upon these small lesions that have been found and the continual coming back. So what factors did you consider? And then how did you finally say, this, I think, is the best choice for me right now?
Okay, I read a lot. I spoke to many people that have been in this situation. I've met with an oncologist, and I really just truly weighed all of my options. And I'm not going to lie, I don't want to undergo a double mastectomy, but I really don't want to get a positive cancer test result. I have 2 children. I really, it's a short-term sacrifice for a long-term goal. And I, again, weighed it heavily and with, as much research as I can. And I do feel that this is the best option for me.
So when you started to talk to all of these people that have been in similar situations, what's the thing that for the ones who chose to have the mastectomies, what did they tell you about the before and after? What did they tell you about psychologically and physically, what that was all like?
Well, from what I understand, it is more of a psychological acceptance than a physical. So I feel that once you can get past the psychological of what is going to happen, if you can digest that, the physical, I have to say, I was actually pleasantly surprised, if these two terms can go together
Yeah,
in this
really.
situation.
Yeah, okay.
Right. They did beautifully. They felt, it took a few weeks, it did, but they felt good. The recovery was not what I had thought it would be. It was actually much quicker. It was more uncomfortable than painful. And I'm more than willing to go through, to go through that if I could avoid
Having
cancer in the future. And I can't put my head in the sand. I can't pretend I want to, but I can't pretend that this is not happening.
Well, it's very brave of you to do that. I mean, I'm not so sure. I don't know how I would react. And I'm sure most of the women who are watching this right now are probably thinking, But we've heard about some celebrities. I mentioned Angelina Jolie in the last segment with Dr. Kaufman. There have been others who have come forward and said, this is what I chose to do. Right. So there's a lot of movement towards it. When you discussed it with Dr. Kaufman, what was he also encouraging of that?
He was wonderful. He laid out all of my options, told me the pros and cons of all. And when I discussed it with him, my husband was at the appointment, and we discussed that we felt this would be the best option, and he was very supportive, and he did encourage the decision. He did, and I trust him.
Well,
I do.
I mean,
have to.
After all, he found something or he urged you to do a further test when, in all likelihood,
Well,
there was no indication that you really needed to do that.
No, and this is my strong message: is had he not told me to get an MRI, I would be walking around. I would not be here today because I would not know I had this.
And even worse, you could possibly be undergoing breast cancer treatment
I
right
could.
now.
For me, I think of the alternative, and that truly gives me strength. And I can sleep at night with this decision because I so don't want the alternative.
Yeah.
So this is what I have to do.
And what about your family? I mean, obviously your husband has been very supportive of this idea, but
Yes.
your mother, I don't know if you have sisters or not, but have you talked to all of them, and have they all said?
They a little bit. I haven't shared it all, but I did.
Well, you have now.
No, I have. No, I have. I have to say, my family that I've spoken to has been very supportive, beyond supportive. Coincidentally, one of my aunts and one of my cousins are also patients of Dr. Kaufman. So they, knowing the situation and knowing him, they know. They said you're in great hands. That's the best decision.
Well, stick around. We're going to wrap things up in a moment. Don't go anywhere. We're going to take one more break, and then we'll be right back with more of CHS Presents Lifestyles at the Heart of Health. Welcome back to CHS Presents Lifestyles at the Heart of Health. And we are joined now with both Dr. David Kaufman and Lisa Hansen with the final thoughts about all of this. So you and Lisa obviously have developed this relationship in trying to guide her through the decisions that she's got to make. I know you've done this a lot, but in each and every case, it must be so, I don't know if the right word is difficult, but there's got to be such compelling and touching moments that are going on there, because these are kind of irreversible decisions she's making. How do you handle that, and how do you guide her best?
Yeah, so you're right. It is very emotional, and thank goodness over all of these years I haven't lost my compassion. So many times physicians, they become hardened or stoic. And I think one of my biggest qualities is that that's never happened to me. And so I treat everybody as an individual. I take every situation separately. It's not one size fits all. And I sort of engage with the patient, the family, get to know her, get to know a little bit about her, and let her know a little bit about me. Mm-hmm. And we sort of just develop this bond, physician-patient bond, and we need to trust each other. It's not only about the patient trusting me, I need to trust them. We're a team, we need to work together.
I've been admiring her bravery, and I'm sure you've seen lots of women who face these challenges and have felt the same way about it. What will her life be like after this? What have you seen?
I think that she's going to have a decrease in anxiety. and an improvement in her quality of life because she's no longer going to have to worry about this dreadful disease.
And that, Lisa, has got to be...
Makes it all worth it.
Yeah, I mean, I could just see the sigh of relief you just gave us. I mean, is there anything you want to say to him right now about what you've gone through so far and how it's worked?
Really, just thank you. There really are no adequate words, but thank you for having the foresight, for putting me on this journey to get to the other side, and for giving me time, knowing that you're giving me more time with my children.
Oh, that's
That's
beautiful.
precious, so thank you.
It's because of women like you that I do what I do. And these types of results energize me and keep me going.
Well, the best of luck to you.
Thank you.
And thank you for all you do. And thank you so much for sharing your story today. We really, really appreciate it.
Thank you.
You may be saving some lives out there by doing
hope
this.
so. I hope so.
And to you too.
Thank you for having us.
And as always, for more information or to schedule an appointment at one of Catholic Health Services' 6 outstanding hospitals, you can call 1-855-CHS-4500 or visit chsli.org. Thank you so very much for joining us today. I'm Jane Hansen, wishing you goodbye and good health.